than the exact time. So this is a new endeavor from my side, and let me just to introduce the objective of this endeavor. So this had been the graduate course for PhD students, and we have two regular PhD students, as is usual. Previously, the PhD or master course students enrolled from numbered by the 2 to 5. Why? Because we have very few nuclear medicine physician and the master or PhD student. So let me introduce to each other. Dr. Asmal Sarkar from Bangladesh. He has started PhD course since 2 semesters ago. This might be his 3rd lecture in my class. And also we have another Dr. Dr. Gill from hospital and also the Department of Nuclear Medicine and first-year resident as well as student. Let me just ask you, Dr. Gill, are you in master course or master PhD combined course?
Yeah, I'm in the sorry, I'm in the combined course.
Okay, so I heard previously that the Department of Nuclear Medicine has changed it to the combined course only. Previously, it took about master course 4 semesters and also gain 4 semester for a PhD course. So it took a while, but according to the global tendency that the PhD course is only set up, and also graduate student from medical school or College of Medicine. In this country, we call it College of Medicine. So we don't need, they should be in the course so many years. So anyway, Dr. Asmal is from the National Institute of Nuclear Medicine in Ninmas, which is called Bangladesh, and he is also, according to the UK system, the kind of benchmarking the UK system, he is considered master, so he entered to the PhD course the last year, 2nd semester. So this is the 3rd semester for him, as I just told. And also, we have, yeah, we have just.
Good.
김동빈 씨, 여기서 모두 음성으로 해버리면 돼요. Okay, so I just I had the host privilege, so I just muted everyone, and if any kind of noise, then I will just do this again. Anyway, so we have 2 regular attendants, and then why we have other participants is because Trans-Eurasian Information Network, which is called TAIN, project had been supported by European Commission for more than a decade to the Asian countries, and we have maintained, we have done with the projects. The first one is finished, and the second one is going on. And according to the project, we have connection. So meaning the international connection supported by TAIN. Recently, they are trying to upgrade from 10 gigabps to 100 gigabps and 400 gigabps between countries, like from Singapore to Myanmar, Singapore to India, India to Bangladesh. That kind of support has been given. So we have just finished the connection to Myanmar last year. So Myanmar is a kind of a newcomer, and other countries are already connected and with a lower speed. So, and according to the COVID-19 pandemic, we don't convene anymore until everything is controlled, and we don't think, we meaning the medical experts all over the world, the doctors and the epidemiologists and the public health experts estimate this kind of situation is going to be prolonged, especially by the failure of the advanced countries like USA and European, the wealthy countries. Nothing is going to be settled down very early. So we needed to find a way to communicate our knowledge and expertise and tips, any kind of information which is going to help people, meaning by way of the enhancing the knowledge and expanding our the expertise and specialty to anyone who is taking care of people of each country. So this TAIN project has established recently virtual online conference or workshop, and this is a TAIN COICA lecture series which I started now. And this lecture series start 2020 second semester, and weekly one, and Wednesday, which coincides with my coursework time, course lecture time, and which it should take 3 hours, meaning 2.5 hour, compact and complete. And I just started 12 o'clock p.m. on time, and we have another online virtual conference series which we had experimented previously in front of the for the international fellows since several years ago. It's because Korea has become an advanced country recently in terms of economy and also the nuclear medicine. How? Because 30 years ago, a pioneer professor who passed away 8 years ago, he established the faculty scientists in my institution for the first time, sacrificing the faculty positions for MD. So I was temporary, and my colleagues were the permanent employee. And I had become the permanent, the tenured, as you have seen. So for conveying the knowledge and how to communicate and collaborate with the PhD scientist faculty, I have the chance and opportunity and luck to communicate with them since my assistant professor years. So that had changed the future. At that time, future, and now the present of the Korean nuclear medicine. So I am trying to deliver this kind of luck. At first, it seems to be a little bit radical for medical institutions to invest to those kind of people. Sometimes I'm doing the all mute here. Anyway, so in summer, radiopharmaceutical chemistry, and in winter, the nuclear medicine physics, meaning instrumentation and tracer kinetic and analysis, or even deep learning kind of new stuffs are going to be delivered. Why? Because those scientists, professors, they are every day, unlike the MD physicians, in any institution in advanced countries and as well as Korea, they do think about how to improve the nuclear medicine by their science. So they have always new stuffs. So it is going to be delivered. It's already established, so it's open, and it had been uploaded to YouTube streaming, and also it was linked in our portal, nmportal.org. So all those materials are open to everyone who is interested by the Geist, the spirit of Creative Commons, CC. So it is not if it is not going to be used as for commercial purpose, it is more than welcome to use without without mentioning or without citing the original source. So this kind of information is going to be, I hope, and we hope, this kind of information is going to be helpful for the catching up next generations of Asian countries, especially 6 countries where I started collaboration. And I really appreciate the help of those countries' leaders, like Dr. Hendra Budiawan. I appreciate you. And the last minute notice, I could just coordinate and organize the final one, because I needed to just sort out what to deliver today. And for 4 weeks, I'm going to deliver my clinical expertise. Interestingly, our Dr. Gil has graduated from a national university, famous national university, Jeonnam National University. So I did not teach him the contents of this lecture. And also Dr. Asmal, of course, he has graduated from BSMMU, correct? Yeah, Bangabandhu, the Sheikh Mujib Medical University. My memory is correct. Okay, so BSMMU is the prestigious school like Seoul National. Or Peter Heskovich, past president, tried to introduce me to his colleague. This man is from the Seoul National University of Seoul, Korea. It's difficult to just convey his intention, so he simplified it. This person is from Korean Harvard. That's all. Okay, so we have many prestigious schools all over the Asian countries, and we need to just establish this kind of lectureship on own. However, at the beginning, we can just do. And we are going to deal with, unlike summer and winter, we are going to deal with deal with the contents as clinical as possible in every subject. But that kind of clinical emphasis is not just the interpreting or explaining or whatever the even though being associated with the everyday clinical practice, everything should be interpreted based on science. So as I just told you, in which our group is strong, and that kind of the Western university type of environment, we were so earnestly and sincerely trying, or they have been trying to establish, in which we succeeded, and we have very good the scientists which who taught me for the last 3 decades. I'm going to exercise their teachings in my presentation. So I have prepared 50, maybe 50, let me just, 51 slide here, which is all related with the clinical. So you can just kind of enjoy in a relaxing way. Why? Because when I had visited Indonesia last year, I found that our colleagues in Indonesia is currently mainly interested in myocardial SPECT, thyroid cancer, and forthcoming, which is going to become more prevalent and popular in Indonesia too, in FDG. And of course, the general nuclear medicine is prevalent, popularly done. However, in case of the already known clinical practice, I also found that every Asian country's experts, their expertise as good as or better than ours. So why? Because their patients had taught the experts in every country: Bangladesh, Indonesia, and Vietnam, and Thailand, Malaysia, and also Myanmar. So that was the introduction. I have used 20 minutes already, and then this content is being recorded, and also afterward this is going to be uploaded to YouTube, and also the link will be open, will be published on our portal. So, and then I wanted from the beginning to make this lecture series to be interactive. Interestingly, since the Indonesian virtual online conference, the 4th of August to the 13th of Vietnam with Vietnamese colleagues, every conference was interactive. So I hope we can use the chatting, and mainly I have two sincere participants. Their responsibility and duty is to ask questions and then answer to my questions. It's a kind of the entire lecture consists of the 150 minutes. Sorry, I'm going to mute all. Entire lecture is going to be 150 minutes, and then I'm going to do the 60-minute and 10-minute break, and 60-minute, and then 20 or more minutes for the discussion. So I just prepared only 51 slides. So this is not going to be a presentation. I'm going to stop and ask Dr. Gil and Dr. Asma. Please don't be embarrassed, because I use this kind of strategy to teach my graduate students of College of Medicine. They called my kind of my style of teaching as a Socrates one, and their response would be kind of silence at first, meaning that my question is not orthodox, and my question is not textbook. We don't deliver textbook knowledge. So this might be a good occasion for Dr. Kil and Dr. Asmal. Dr. Asmal had experience when Dr. Kaid was here, and with the 5 international fellows, while just kind of reading cases for educational purposes, I just raised a question, and I remember including our residents, 6 of them, all of them failed to answer the correct one. Why? Because correct one is based on common sense, and we have too diverse information, which is bothering. So that's my opinion. Okay, let's move on. Yeah. So let me just kind of now, once I announced this kind of occasion and opportunity for Asian students, no, not students, Asian, the next generation leaders, which are mostly physician residents or even fellows. Everybody is welcome. And please use this kind of lecture time. Please ask me a little bit the difficult question. Then I would just kind of answer, because this is weekly one. And also from today until the Professor Edmund Kim is arriving, he is going to arrive here 6th on Sunday this week. And then he's going to be on quarantine. Why? Because he's coming from USA. So he is going to be quarantined until 20th, 14 days. And 3 weeks later, once he is coming, and I'm going to make this 10 lecture series, 2020 second semester, is a distinguished lecture series dedicated to Edmund Kim. Edmund Kim, Ed Kim, Professor Kim, they agreed immediately when I asked 1 month ago after a successful Indonesian virtual online conference, the night of that day, the seminar day, essential seminar important day, I'm going to remember that the 4th of August, the first successful interactive meeting. So that night, I just sent an email several hours after. He replied, of course, super. He is more than willing to give lecture series. And I will ask him. He needs to use 2 hours and 30 minutes. So the participant from the sorry, mute all to avoid noise. Participant from the catching up Asian countries are all young, and they are full of curiosity and full of questions. So please encourage them as if they are in University of California Irvine Hospital, or better than UCI, is as if they had visited a previous Professor Kim, Edmund Kim's office, I mean the lab or department in MD Anderson Cancer Center. He had been there 32 years to teach many students and residents and fellows, and so as is well known, this is the kind of a first semester. At least he's going to deliver 4 or 5 lectures, and I'm going to ask him more, and he is willing to even study de novo, and he's going to kind of summarize and and digest, and then will deliver. And as is well known by our experience, this lecture is with a correct English. Why? Because he stayed in the States for 40 years, and correct English and correct science, and more importantly, the correct nuclear medicine. And he's a textbook, and he wrote many textbooks. Okay, that's kind of advertisement. So now everybody would be a little bit bored by the non-academic one, so I'm going to go into the details. Today's topics is going to be completed today. And next week, I'm going to deal with another. So topics is always starts from the physiology and radiopharmaceutical science and physics. Please enjoy how I'm using the knowledge in the radiopharmaceutical sciences and medical physics or nuclear medicine physics. And in case of myocardial SPECT, gating was a kind of innovator and stimulator and booster. And if I just tell you the statistics all over the world, several years ago, I just kind of collected the information regarding how many cases are being done by the world, and also by each countries. So ignoring the details, just let me take an example. In case of the United States of America, they are doing 20 million cases per year annually. Half of them, 10 million cases, are myocardial SPECT, gated myocardial SPECT. And gated myocardial SPECT has replaced to yield ejection fraction of the left ventricle and also the end-diastolic volume and end-systolic volume and stroke volume. And nothing is trustworthy from echocardiography, even though echocardiography has evolved to 4D. They called it 4D, and even 5D, they just kind of did a semantic, semantic circus. But gated myocardial SPECT has made myocardial SPECT as a one-stop one. Only the competent is gated MRI, but gated MRI, even though the MRI technology has improved a lot, patients are in the gantry. Heart patients cannot lie down very well. So every kind of technical difficulty, and there is no physician in MRI room. So if the patient is complaining chest pain after stress, or complaining even cardio, emergency CPR, resuscitation is needed, then it is kind of no physician area, even in the hospital. So MRI does not allow the magnetic or metal or that kind of issues. So I don't think the MRI is going to compete with the myocardial SPECT. So gating has a clinical application. And the most important one, the after break, I'm going to deal with the clinical decision making and real topic of how to use myocardial SPECT in clinical situation. And I can just say that nuclear medicine physicians, and actually every clinicians, are Bayesian. So we are going to say that Bayes theorem. Bayes theorem is the most easiest theorem, as I remember. So even though you are not quite familiar with the Bayesian, and Bayesian was that belonged to the kind of a topic, a peripheral topic, while you were second year, the graduate student in College of Medicine or medical school. In the lectures of lectures and lectures by the preventive medicine professors, it is not the case. Every clinician is a patient, and let me explain it. And I'm going to just to ask you at this time point, the situations in need of myocardial SPECT, why we should do, and when should we do, and when what are expected, what kind of measures, measures meaning treatment or no treatment is going to be expected by based on our findings of myocardial SPECT. Please pay attention to today. Please consider me as a nuclear cardiologist. Actually, I have been nuclear cardiologist for almost 20 years, and I left myocardial SPECT. Why? Because myocardial SPECT had become, during my 20 years, myocardial SPECT had become the bone scan, meaning there is no more need to do the study. We need to use that the practice. And let me just comment about the situation of the nuclear medicine physicians in the United States. The half of the 20 million, 10 million myocardial SPECT cases are being done by cardiologists. They call themselves nuclear cardiologists. They don't know anything about the radioisotope, radionuclide, radioactivity. However, they are best experts in heart. So they do myocardial SPECT, and there is kind of conflict of interest, meaning self-refer. They do take care of their patients, and they do refer myocardial SPECT, and then they do myocardial SPECT. That's kind of a problem of self-refer. However, in the States, the cardiologists are the best quality of people, experts, medical experts, in the entire discipline, including every kind of surgery. So the cardiologists, they save the people. When I was a student, when I read the Harrison and Cecil textbook of internal medicine, in the chapter of the acute myocardial infarction, I clearly remember that half of the patients who are coming to emergency room in the Western countries are going to die. So in the emergency room, triage is important. Once they arrive, and if they are in kind of a cardiac shock state, then as well as the resuscitating, that trying to resuscitate the patients, you need to find the patron, family, or champion, and teach them. This patient has a chance to die more than 50%, and that's very important. Why? Because the doctors are teachers, not just to the patients, and but also to the families. Okay, so 5 is just kind of how to amalgamate these knowledge to teach peer clinicians. Peer clinicians meaning our clinician colleagues. They really want us to teach them. Even cardiologists. Cardiologists are very good at physiology, but they don't know anything about the physiologic imaging. They do just kind of best expert to save people. So, in my early career, for 10 to 20 years, I was so happy, so lucky to have a very good cardiologist colleague and very good cardiac surgeon colleague who really depended upon me Why? Because at that time we have three physicians, faculty physicians in my university hospital, and the senior who just retired, who previously retired, was mainly interested in brain, and the another senior who just retired were mainly interested in tumors. So heart was my discipline. So I took care of any kind of heart-related issues, even diabetic heart. So after several years of struggle, I could just have the confidence from my cardiologist colleagues and also the cardiac surgeons colleagues. And we have done post-operative, post-cardiac bypass graft surgery, post-CABG, myocardial SPECT, in number, more than Johns Hopkins. So we were so happy to see the quality and performance of our the cardiac surgeon. He was willing to be evaluated by objective method like myocardial SPECT. He did not believe echocardiography. He, at that time, there had been no cardiac CT, no cardiac MRI available. It was still in a research phase. So he said, during my early days, I adopted the, at first, gated SPECT, and then attenuation corrected myocardial SPECT. And I found that attenuation correction with line source, which costs $20,000 per year from the research fund, and I found that the attenuation correction is not helpful. So maybe we were one of the first who reported that attenuation correction is not needed. However, in the American College of Cardiology annual Congress meeting, entire floor was full of cardiologists, and I reported that this is not going to help the clinical decision. And they were so, they have got so angry. And unfortunately, I have been given 15 minutes, but I have spent only 8 minutes. So we have 7 minutes of discussion time. My English is academic one, and English is short, but all the two chairmen and also the best experts in United States, mostly cardiologists, they got upset and they tried to torment me, even crucify me by asking questions. I needed to answer several questions. And among them, the introducer or inventor of the attenuation corrected myocardial SPECT was there, Dr. Picaro from Michigan. His face had become red. He was so upset. So he even stuttered in asking questions. But I was just kind of repeated my findings. And that finding was finally published in the Journal of Nuclear Medicine. And interestingly, around that time, everyone seemed to agree that the myocardial SPECT need the attenuation correction. However, since that time, you might know that we are not doing attenuation correction. It means that the clinicians do not want any kind of that kind of improvement. However, gated SPECT, everyone is doing gated SPECT. So I'm going to explain the success story of gating. It's just a 3. third one. Okay, until now, this kind of information is just kind of monopolized to me. So you just kind of be overwhelmed by the new information, our plans and the Professor Kim's story, and also my anecdotal experience 20 years ago when I attended and presented the uselessness of the attenuation correction based on our data, and then I'm going to move on to the physiology and radiopharmaceuticals and physics. And you might just kind of all these informations are in the textbook. What I had done is just editing. Fragmented knowledge is there, but as a clinician and physician and nuclear medicine expert and clinical physiology expert, and let me just tell you, not because I am from internal medicine, but because I majored in nuclear medicine. My cardiologist colleagues, they are usually self-confident, and they are self-conceited, and they are so aggressive like surgeons, and they do not respect colleagues very well. So it is very hard to get a respect from the cardiologist. Even when I was in United States, 1993, their nuclear cardiologist studied or had been read and done by the, of course, in the United States. I worked under the supervision of cardiologists. Cardiologists turned into the nuclear cardiologists. They told me that once they knew I am from nuclear internal medicine turned into nuclear medicine physician, even though I am from internal medicine, they joked. They joked that they gave me the job. In the hospital, there are two types of the experts. One are cardiologists, and the other is non-cardiologists. So I belong to, as an endocrinology expert, I belong to non-cardiologists. So, and then they continue the joke. Please learn from them as many cardiology as possible. So I learned a lot from them, and I really appreciate their help. And it was a good old days. It's kind of anecdote. And then serious the science and medicine now. First, why we are concerned about the myocardial stress? Physiology. It's because we are doing stress test. In my career, I have done, and many CPR, cardiopulmonary bypass, and cardiopulmonary resuscitation, during or after stress. Previously, we used dipyridamole. Dipyridamole, their drug, the action time is a little bit prolonged, and we could just lose patients during and after the stress. So we need to be respected. We need to get the confidence that once our cardiologists send their patients to our department and laboratory, and then they don't worry that we are going to harm their patients. So I needed to just to study. Actually, I was much more interested in molecular biology after finishing my school years, and when I was being trained, had been trained as an internal medicine physician, I was much more interested in the molecular stuffs, but I needed as an assistant professor who is in charge of the heart study. I need to learn the physiology from the textbook of heart, thick heart textbook. And it is kind of formidable to understand and dig into the thick heart textbook, but it was easy. Why? Because I had a stance from the nuclear medicine, tracer kinetic, and in everything, meaning the according to the degree of the stenosis of coronary artery and the area velocity is equal to flow. That kind of simple and easy to understand the physiology, the ideas are going to be being exercised by nuclear medicine studies. So it was easy. So let me just tell you, if we did do the stress study to our patient, and coronary artery blood flow is going to increase. So exercise is a kind of a usual one. And we can just mimic exercise by the sympathetic, the stimulant, mainly dopamine, not catecholamine. The traditionally, our cardiologists, they have used the dopamine, so we inherited their use from the dopamine echocardiography. So exercise and dopamine has a same physiologic the stimulant, a little bit different. Why? Because the systemic venous dilatation and also in case of exercise, that kind of details. However, interestingly, dipyrdanol or adenosine is also mimicking. So here, Dr. Gill, I have a question to you. Exercise and the adenosine does have a different mechanism. However, their the result is the same. Coronary artery blood flow, coronary blood flow is increased. The amount is 2.0 and 3.5, and please disregard. Why? Because exercise and adenosine, if it is given to different people of different ages, it is going to be different. So 1.5 to 2.5, 2.0 to 2.5, and 3.5 to 4.0. If this kind of slide is given to the students, they memorize it, and they expect at the term examination, this kind of difference is going to be asked. No, not the case. Coronary blood flow is the same. Then my question is, what about the side effect? The cardiac arrest or the serious event, or any kind of the serious arrhythmia and death, that kind of side effect. Which one is more harmful with the side effect? Would you?
I think that dopamine is more harmful and adenosine
Why?
is safe. It's mainly because dopamine.
No. My question was different. Please listen carefully to my question.
Yeah.
I am not interested in dopamine. if I'm going to revise this one, I'm going to just erase dopamine. We did dopamine myocardial SPECT in my career, but I don't believe the authenticity of the dopamine stress. If you are interested in dopamine, if the patient has a healthy leg or healthy lung, then you need to do the exercise. But exercise is too cumbersome. We need exercise technician. So exercise and adenosine. One is pharmacology, the other is physiology. So both are going to just result in the same amount of increase of coronary blood flow. And what do you think? Which one is more the higher incidence of side effects, and why?
I think exercise is more harmful than other
Why?
issues.
Yeah.
Yeah, it's mainly because exercise, the action of exercise is kind of related in such a whole body things. But
Then yeah, okay.
Yeah.
Then when you just kind of answer, this might be the first day. Please speak a little bit louder, even though yeah, okay, sorry. Let me just I had almost the full volume. So then let me challenge you. In case of exercise, it is up to patient. Even though we want them to reach the submaximal the heart rate, which is 85% of the maximum heart rate, and I'm not going to tease you. If you were my the medical graduate student and they are going to be given the question, the maximum exercise, maximum heart rate, what determines maximum the heart rate? So they are kind of they used to be embarrassed because they just memorize everything, and they don't have any capability to just to apply that kind of knowledge to the field. So that's the reason why we do have a kind of a small group discussion to just refine their knowledge, how to integrate. So let me just give you the answer. The age determines, not gender. Age determines, and then every person of certain age has a maximum heart rate, and 85% of heart rate is going to be encouraged to reach during treadmill study. However, that's patient will. Patient is going to stop because of that they are so they are suffering such a shortness of breath. Sometimes they are the knee is aching. Sometimes their lung with a chronic obstructive pulmonary disease does not allow them to so exercise can be stopped. If chest pain comes, they immediately stop. After exercise, this is not going to be asked again because of for time's sake. Our graduate students should answer to my question. After exercise, the increased blood flow, how long would it take that increased coronary blood flow is becoming to normal? We need to know that. Okay, that's very important information, which is usually disregarded. You know, I was the person for the several decades to teach exercise physiology to graduate students. Why? Because I am nuclear medicine physician, and I am seeing every day, the morning and afternoon, the results of the stress study. So then I would just kind of challenge you. exercise according to the patient will, they can stop. But in case of the pharmacologic stimulation, drug has been already given. No way to reverse it. So you're saying that exercise is better, right? Exercise is worse or better?
Yeah, exercise is worse.
Yeah. So then, how can just kind of how can answer reply to my challenge? Exercise is better. Okay. And what kind of information is needed to solve this the question, this puzzle? Dr. Asmal, do you have any help? What kind of information is needed to solve this problem? And where
we
can
need,
yeah.
we need to select the patients carefully before pharmacologic stress. And
no, even in the department doing both exercise and adenosine, we don't select. Maybe the cardiologists would select. Cardiologists, if they prefer the exercise study, and if they prefer pharmacologic study, they would just kind of triage and send to us. Then we just obey their order. So what I'm saying is just, as you just kind of observed, in my department, no exercise studies is being done since the introduction. And let me just tell you. So actually, my students should just kind of invent the answer. And after 10 or 15 minutes, within 10 minutes, interestingly, my students, consisting of 10, they, for the first time in their life, they could find the answer. Why? Because they are so fresh and full of information, new information. What they don't do is just kind of integrate. So that's the point of my first hour. Okay. So let me just disclose the answer. If you are going to, Dr. Gil, you are going to answer confidently and surely say something to my question, is you need to just kind of do the prospective study of 100,000 exercise cases and 100,000 the adenosine study. So the people who first introduced adenosine study in the clinic, they did it. So what we need to do is just kind of to look for textbook or internet review article. So interestingly, my students for the last 30 years, they almost all of them found the answer. 20 years ago, the correct answer was that kind of information would have been in the textbook or review article. Since 20 years ago, almost 10 years ago, answer had become different. You know, the bright student has just invented a new answer. Why don't we just look for internet, Wikipedia, or whatever information source is going to teach us? Why? Because every clinician should choose between exercise and adenosine. So, and adenosine has been introduced later. So according to the textbook and the prospective study, the death rate of both the stress study and also side effect, mostly related with the chest pain and acute myocardial infarction in case of exercise. In case of adenosine, it is different. The bradycardia related the pump failure or acute myocardial infarction because of the coronary stir, and also asthmatic attack. And both are suffering from the arrhythmia, fatal arrhythmia, and incidence was the same. So which one is worse? That's the trap. The students are separated into two groups. Exercise is worse and adenosine is worse. So I have the solution. Why? Because I have seen already the meta-analysis results, which was reported 30 years ago, and most of you would not be would not be paying attention to. So I have I am the one who observed the progress. So when we for the first time did the adenosine, I was so concerned if this pharmacologic stimulus is going to be. However, in case of adenosine, it was much safer than dipyridamole. Why? Because their blood half-life is so short. We all know that 75 seconds or something. I forgot the detail, but it is good. Okay, we've spent just 1 hour. We are going to stop here and take a 10-minute break, and we are going to just kind of get the speed pedal. And I'm going to ask you, Dr. Gil and Dr. Asmal, please don't be bothered to answer the correct answer. Every kind of my question is like this. And nothing is going to be in the kind of term examination. This is kind of discussion directed the questions, and I have exercised that. And this kind of knowledge is going to make us to be respected by our cardiologists. If we don't know heart and heart people, patients, then we are going to become the technologists. We are doctors. In our hand, if we are doing the stress, and then patients are going to become bad, then we are going to resuscitate them, and then make them just before stress, and then send back to their the doctors. So we respect. And interestingly, my cardiac surgeon sent 100% of his post-operative patients 6 months after, 1 year after, 2 years after, 4 years after, 5 years after. So we know that their the surgical skill and surgical post-operative care and perioperative care was the best. In Johns Hopkins, I read in the paper, they are sending only 2.3% of the patients. Cardiac surgeon do the coronary artery bypass surgery, even though he is doing so many cardiac surgery, coronary cavity surgery, but they don't send their patients to myocardial SPECT, and they do send their patients to echocardiography. And echocardiography, the problem of echocardiography, I'm going to explain in the next one. Okay, now the 1 o'clock, 5 minutes, 6 minutes, and 10 minutes later, 1:15, we will come back. And I will take the speed. Where is it? Okay, welcome to come back. Okay, so the second hour, I mean the second 60 minutes are going to be started with this kind of very easy And when you are the junior professors who are kindly attending this kind of a little bit old-fashioned lecture, so when you're trying to persuade clinicians and also the medical students, we are using this kind of examples. Left anterior descending artery, circumflex artery, and also left circumflex and right coronary artery, if they are the stenosed significantly. So significantly is a meaning. And area 50%, or area 70%, or area 85%, diameter 50%, diameter 70%, and diameter 90%, or whatever. The kind of the arguments have been there. Maybe some young physicians, nuclear medicine physicians, you are not quite familiar with that kind of, however, 25 years ago, when I attended the cardiology meeting and also nuclear medicine meeting in the United States, there had been a debate and even one session that the anatomically significant disease, how well can they be represented by myocardial SPECT? As a person, I mean the individuals or individual artery territories. So now, the long story short, conclusion is myocardial SPECT is gold standard, or if you just kind of a little bit cautious, a silver standard. Gold standard is a PET. So the tissue perfusion is actually is the final holy grail. So myocytes are in that condition. We are seeing that. So the stenosis might not be a problem if it does not show any tissue perfusion abnormality, especially during stress. However, that kind of statement has a problem. Why? Coronary artery, no. Myocardial, cardiac myocardial perfusion is dictated by the coronary artery stenosis, the degree of stenosis. So my previous statement is in that sense practically wrong. So we don't argue that the tissue perfusion is superior to the coronary artery stenosis. The studies to find the stenosis of the coronary artery, like contrast angiography or CT angiography. So that's the message from these images. And interestingly, this was the first version of the gated SPECT. Do you find anything interesting here, Dr. Kill? The mesh is end diastolic, what the border, and surface is just kind of a movement of the endocardium, end diastolic endocardium, and then moving endocardium is this image. Is there anything wrong, Dr. Kill? Or if anybody from the Asian countries, if anybody find anything weird or wrong, you can just kind of unmute you, and then just to say anything. Okay. This is a nonsense quiz, actually. Dr. Kill, so you are losing your time. And Dr. Asmar, is there anything weird, strange with this kind of a gated SPECT? So while you are looking for any kind of Wall-E or any kind of the strange thing in here, let me just tell you. At the end of this century, around the end of the century, a southern Italy, a very good scientist, PhD, physicist, they had originated from the southern Italy. At that time, worked in Southern California, not University of Southern California. Actually, he worked in Cedars-Sinai, not cancer center, Cedars-Sinai Hospital in California, with Daniel Berman, who is an eminent nuclear cardiologist, and cardiologist turned into nuclear cardiologist. Daniel Berman, he invented this method. And at that moment, there had been several lines of competing algorithms from Michigan, from Harvard, from wherever else, and then from him. His name is Guido Germano. Dr. Germano, with this kind of achievement, had become the fellow of American College of Cardiology. And he earned a lot of money. Why? Because at first this method was adopted by ADAC company, which was later merged and acquired by the Philips company. So Philips microspect machine was the first one. No, ADAC, the microspect machine, was the first one who just kind of installed this method. And then at that moment, and Siemens and GE and others, Sophie and Picker, those companies try to develop their own, but finally they just kind of purchased this software to be installed. So these days, every the machine, microspect machine, has installed this, and this is the first version, and we teased at that time, and we always joked, please don't let the engineer do their thing. Okay, all right. So too much time. Dr. Kir, you don't know? In heart, have you found anything?
So I'm not sure.
So no heart has a superior wall. Okay, we have used this software for several years. Why? Because they submitted this software to FDA, and FDA approved, and no word or no even period or the comma should not be changed after getting approval from FDA. We learned at that time, so we were so embarrassed to explain to our clinician colleagues that the output was so good, gated SPECT. However, it had a superior wall. Myocardium does not have any superior wall. It should be anterior wall, right? But maybe someone would have given to the engineer inferior wall, and then immediately he just kind of put superior wall there. There was no the computer or no the microspect machine does have this kind of, that's kind of a anecdotal one. And when we found this, I was so happy. Our first gated SPECT study, published in Journal of Nuclear Medicine 20 years ago, was without border. So we were just trying to figure out myocardial thickening only with the count, without this kind of border, white line. So it was so difficult but possible. So for the first time, we found that after the stress study, ischemic insult is going to make the myocardium stunned, meaning the wall thickening was decreased. Even after 4 hours, even after 24 hours, some of the stunning has sustained. That kind of issue was evaluated with our SPECT study. So we are trying to compete with the echocardiography. And finally, we were successful. Why? With this data. It was published in Nuclear Medicine Communication from British Society of Nuclear Medicine. That's my paper. We did reproducibility study. Why? Because gate SPECT with the same data, with the same the parameter, meaning the same ejection fraction and the same end-diastolic volume, then the same end-systolic volume. That software was so exact, 100% correct. Then what is the kind of the variance? This is twice. We imaged the same patient twice. Patients lie down in the myocardial SPECT. At that time, we did not have any sitting type of myocardial SPECT. Patients lie down and almost asleep. One round is 15 minutes, and another round we get the informed consent, and that's two separate acquisition. And then we measured, because the same images are going to give us the exactly same data. We were so sure. So this is kind of a physiologic variation. Patient's heart would have a several percent different. And here there is a mislabeling. Ejection fraction is 40% and 240% is really interesting. Okay, it should be the end-diastolic volume. The second one should be end-systolic volume. The last one is the ejection fraction. So that's kind of a trap to entertain our students. And okay, and then physiology more again. Now that's the information which has been derived from physiologic measurement by tracers. 50 years ago, nuclear medicine was doing this kind of physiologic measurement. And cardiac output, how did it measure? Was it measured? It's kind of a catheterization or gate SPECT. Not gate SPECT. Actually, they have used echocardiography. So that's the information. Here cardiac output in normal adult. Dr. Kill, what is the normal blood volume?
Normal blood volume in adults?
Yeah, in adults.
About 5 liters.
Okay, then what's the difference between the blood volume and cardiac output?
Cardiac output means blood volume, like stroke volume multiplies heart rate. So cardiac output is about the
why I just invited you to answer that question is, please trust me, our third-year students, almost 95% of the students do not know the difference of cardiac output and blood volume. All of them know that the cardiac output is 5 something, and blood volume is 5 something. But when I ask them how large is the cardiac output, then almost everyone is saying that 5 liter. Oh, is it so? Then what about the blood volume? And again, 5 liter. Then what's the difference? And they are in dilemma situation. And we need to just to kind of teach them. Interestingly, our physiology faculty, physiology professors do not teach them, or they would have taught them in March of the freshman course. And after midterm examination, students would have forgotten everything. And after 2 years, they appear in nuclear medicine, and they used to be asked by myself that how much is the cardiac output? 5 liter. How much is the cardiac no, not cardiac volume, the blood volume in the adult? 5 liter. They don't know, and that's the kind of a starting point where the students do not understand myocardial perfusion imaging. Please trust me. And today is not the time of the how to educate, how to teach our students. So that's and then renal blood flow and renal plasma flow at GFR all are kind of intertwined. That's the physiology. And tissue perfusion, meaning myocyte is receiving how much amount of what? Blood? No. Blood is not coming to myocyte. Only oxygen and is the substrate, nutrient substrate like glucose or fatty acid. So, however, if tissue perfusion, tissue blood flow is blocked, then it is not going to be. So, according to the tradition and the textbook knowledge of the modeling, this was pioneered by Dr. Kitai and Dr. Schmidt and Dr. Rankin and Dr. Krohn. There are 2 ways of looking at the problem and then modeling. And this is has been done almost 50 to 40 years ago. It's textbook knowledge, and based on that, we now know that the clearance type of the concept is derived from here. Clearance is flow is there. Clearance is extraction. So flow multiplied by extraction dependent upon the permeability surface product. If surface is large, clearance is large. Permeability is the large, and then clearance is large. That's so simple. And the extraction type of or extraction coefficient or clearance is according to the Rankin-Krohn model, and Kathy-Schmidt model is, in another word, is called Compartmental Model, and this is going to be used by our colleague Professor Jae-Sung Lee when he was a PhD student. We did a lot of study to understand, to follow the trace kinetic ideas in the field of tracer kinetics, which was developed by the pioneers who were so brilliant at the time, like molecular biology of the 50s and 60s and 70s are PET, positron emission tomography studies, and then, according to this kind of extraction, the coefficient or the clearance, water is flat. Why? Because the water is a gold standard substance, and rubidium is a little bit lower, and thallium is lower. I did not draw MIBI. So MIBI has a much lower, kind of much earlier saturated. Whatever the explanation. And interestingly, this is more important, FDG. never to represent flow. Why? It's totally independent of flow. So it takes about 40 to 60 minutes to saturate the capacity by the action of glucose transporter and also hexokinase. They are going to trap. So they are going to be trapped. However, FDG, the determinant of trapping was not the flow here, according to this data. It's a flat. The flow, even though flow is increased, FDG pad uptake is the same, clearly. However, if something, MIBI, sestamide, or tetraphosphamine, my view, if this is going to become the blood flow agent to represent myocardial blood flow, they should be trapped. Okay, and heart is 300 gram and 70 kilogram patient per gram injected dose to the MIBI taken up by the heart myocyte per injected dose, usually 0.4% is an even one. And according to the radiopharmaceutical vial insert of the MIBI and tetraphosphamine, the vial insert, which was approved by the FDA, they are saying that it's 1.4 to 1.0% ID per heart. Tetraphosphamine is 1.2% ID per heart. It seems to be the same. But I don't think this is going to be correct. Why? Because I have an experience when the tetraphosphamine was first developed. They have brought tetraphosphamine to me and to land to my hospital. So they have test kit to me. And I tested that time. In one day, everything has been changed to tetraphosphamine. We got several myocardial SPECT study with tetraphosphamine. We found that myocardium has darker imaging. So I asked at that time the scientist who represented the tetraphosphamine producing company. He confessed that MIBI is taken up this amount, tetraphosphamine is taken up by heart less than half. So he agreed with our data. With the same acquisition protocol, with the same amount of 25 millicurie, tetraphosphamine image was darker. That's the reason why we did not use in our lifetime tetraphosphamine. But interestingly, tetraphosphamine has landed, has been approved, has landed in many institutions. And we know that during Society of Nuclear Medicine meeting, if myocardial SPECT image is a little bit darker with the same machines, then we immediately noticed that the tetraphosphamine would have been used. The character was the same, but the contrast and figure of merit was lower. So if somebody is interested in using tetraphosphamine with a old type of myocardial SPECT machine, then please pay attention to the quality. And also, if tetraphosphamine is half the price, and then I would use them. If they cost the same price, I don't recommend, according to my experience. I don't know how tetrophosphine has this kind of value according to the FDA approved the vial insert, the information sheet. Okay. And for this kind of the tetrophosphine and MIBI, we use this one. Technetium has a many different oxidation state, and technetium MIBI is using +1. After, you know, the technetium has this kind of oxidation state. After labeling MIBI, MIBI has this kind of, so if technetium has a chelate position, technetium is metal, and MIBI is chelating technetium, and then positive 1 ion. So it was really, really interesting that positive ion is taken off myocyte. So, but it was the case. Usually it should have been the neutral. Every other company was trying to develop neutral type of myocardial imaging agent. They failed. So still, in radiopharmaceutical chemistry, there is a kind of puzzle and secret which cannot be. And finally, everyone is saying that the thallium is also taken up by the sodium-potassium ATPase activity, and then MIBI is taken up by the mitochondrial something. And is it important? No. Now, after 20 or more years of popular use of MIBI and tetrophosphine, nothing is important. What's important is how to make a very good image. So, Dr. Gill, we need to think about, there are many filters pre-processing here. We used to use the Butterworth filter. We use the Parsons filter, Hanning filter, and ramp filter. Ramp filter is the high frequency is not the abruptly suppressed and then noisy looking, and HART was like that. These days, SPECT, we are using SPECT, and we are looking at the more noisy one. I'm so addicted by this type of image. So I'm complaining every day that we are looking at much noisier images. But interestingly, this kind of image or this kind of image, you know, the high frequency. This is a frequency. The horizontal axis is meaning after fast Fourier transformation and frequency. Okay, this kind of thing can be asked at any time to Professor Jason Lee. No, you can ask chief technologists. They know better than us. So they are our colleagues. They are making a very good image. So please don't use snapshot image. Even though they are good, making snapshot is going to make a noise. So which is kind of confusing your eyes. Please blow up the transaxial, no, actually short axis, synchronize rest and stress, and then the scrutinize, and then got your idea, especially after looking at this one. If there is a resting perfusion decrease, but thickening is 1 centimeter to 1.60 centimeter, meaning 60% the systolic thickening, not thickness, thickening, then that the apparent perfusion decrease is an artifact. No myocardium with decreased perfusion can contract normal. Okay, perfusion decrease because of the breast attenuation or because of the diaphragmatic attenuation can be explained with this one. So our final one here, normal thickening, decreased perfusion artifact. So gated SPECT has helped a lot. So if echocardiography, even if echocardiography or the gated MRI, they are going to give us the information about the thickening. They are not good at giving us the information regarding perfusion. But we can have that kind of information here. Okay. And then let me skip the partial volume spillover effect like this, because the heart is only 1 centimeter thick. Usually fully with half maximum of myocardial SPECT is still 1.2 centimeter, meaning we need 2.4 centimeter to have full count, or there is a partial volume effect here. I'm not going to explain in detail here. And using Laplace transformation and also solving the differential equation of the activity there, Professor Jason Lee estimated myocardial blood flow and made a parametric image here 20 years ago, which is not used. And here, to understand this kind of information, we need to understand the alpha is partial volume and spillover, and we need to understand the F flow, and also here, where is it? Yeah, alpha. No, not alpha. Where is it? Oops. Yeah. That's a combination of large K1 and large K2 is making a partition coefficient here. So partition coefficient, which I'm going to repeat in our third lecture, while I'm trying to just to say to you what was that. 2 weeks after, I'm going to explain to you. Maybe I'm going to make all the participants sleep. I'm concerned, but the third medical doctor's view of tracer kinetic is going to be explained, and I will come back to this idea again. And before that, I'm going to just make a PowerPoint having a note so that everyone can preview that. Okay. So now after talking about the partial volume effect, now I have how many slides here? How many slides? It's almost more than half of the slide, but 10 minutes. You know, I failed to arrange time. No, I intended to just kind of fasten my explanation. And this explanation, you cannot follow me real time. Afterward, you need to just kind of scrutinize the equations and calculations, and then you might just come back. Okay, how to use the myocardial SPECT? of the in clinical reality, and how our clinician colleagues, who are cardiologists and cardiac surgeons, how they are using the myocardial SPECT should start with the information, with a kind of concept, with a notion that the triage of the patients with suspected coronary artery disease, and at the turn of the century, we were so eager to understand, based on the clinical likelihood, clinical probability of the prevalence. We say that low likelihood, intermediate likelihood, and high likelihood. What kind of information should be put into this one? Dr. Gil, what kind of information is used for clinical likelihood, for determining clinical likelihood, low, intermediate, and high?
Some symptoms like chest pain or some laboratory blood laboratory test like troponin I, such a kind of things.
Yeah, so classical incorrect answer. Dr. Asmal, what kind of information is needed to determine likelihood of coronary artery disease? That coronary artery disease meaning coronary artery obstructive disease.
Demographic characteristics and risk factors.
Okay. That's all?
And
yeah.
Also symptoms.
Yeah. So please elaborate a little bit. Demographic factors, yes, correct. But it's more than demographic factors. So let me explain my experience. When I had been in conference with cardiac surgeons and cardiologists, the first year residents, they are presenting their patients. They are trying to present all the details of their patients, but after a short while, the professors in cardiac surgery and also cardiothoracic surgery and also cardiology, they blame and then blame the chief resident. Please teach them to present the necessary information, and unnecessary information removed. So after a while, I found that the first year's resident, like Dr. Kill, if they say that troponin and they say that the chest pain pattern, then chest pain is okay. No. They used to say 67-year-old male patient without hypertension, with diabetes, without the history of acute myocardial infarction, chest pain was not or was complained, and then his past history of the cigarette, 60 pack year, that kind of information. So age, gender, diabetes, hypertension, and also EKG abnormality, past history of exercise past history of acute myocardial infarction, meaning Q wave, the presence or absence of Q wave, even though the patients did not say anything, and laboratory test not troponin, lipid profile, okay, hypercholesterolemia had been which were not treated or something, and then that patient. Then the patient, that kind of information is going to determine likelihood. If you don't understand this one and the next imaging study, you cannot sell your imaging study to anyone. If you say that this patient is likelihood or something, and you don't understand the likelihood, then your clinician colleague immediately say that this patient, this nuclear medicine doctor is a technologist. We just send and we just receive. and they are they feel frustrated. They think they don't have any nuclear medicine physician. That's the reason why in United States, every nuclear medicine physician who are major expert, the world-class expert in tumor, they are not actually respected by the cardiologists. Cardiologists seek for cardiologists. They are using the same term. So that's the one. Okay. So that's the reason why I just put the last 10 minutes. However, I was wrong. Last 25 minutes. I started the second hour at 15 minutes after 2. So still I have. So previously we used the nomogram, but these days, if you just they put some into your not laptop computer, your just a smartphone, then it is going to give us likelihood who is the likelihood or the probability is 15%, and probability is 45%, probability is 95%. If the probability is the 95%, there is no need to do myocardial SPECT or contrast echocardiography. Any kind of CT angiography is not needed. Directly send to the contrast angiography, and then one step the PTCA or the percutaneous intervention PCI, or determine this patient should be sent to the cardiac surgery. That's how they do it. So this kind of information really important, but I have not recently listened to this kind of lecture to the nuclear medicine physician, next generation nuclear medicine physicians very often. Professor Sang-Gun-jo of the Jeonnam National University, or Professor Jin-Cheol Peng, or Professor Won-Jun Kang in Yonsei University, Severance University Hospital, or Professor Heli Bong. They do exercise this kind of information transfer and information delivery. But the most expert from the United States, they don't understand. If you listen to that kind of information, you need to just kind of attend American Society of Nuclear Cardiology, not a Society of Nuclear Medicine, right? However, in Asian countries, we do the nuclear cardiology study. So we need to understand, no nuclear medicine textbook is detailing, is kindly explaining this. So we need to just kind of, you need to share as many time as your cardiology or cardiac surgeon colleagues. That happened within my 20 years. Now, Professor Jin-Cheol Peng is in charge. And interestingly, retrospectively, 20 or 10 years ago, I reviewed the patients' pre-test likelihood. What I'm saying, the myocardial SPECT patients, their chart I reviewed, and not I and my team, previous fellows and previous residents reviewed. We found that almost everyone belonged to the intermediate likelihood, 15 to 85%. So we found that we are doing very good the clinical practice. Why? Low likelihood, there is no need to do imaging study. We are using radioisotope. Radioisotope, if it is not helpful, then there is no need. Okay? So this was the one. However, this has been changed because of the introduction of what? Introduction of, this is a current triage of patients with suspected coronary artery disease, then and now. Now was mid-20s. 2000 something, our nuclear cardiology colleagues, they have changed low to intermediate likelihood. CT coronary angiography is the first choice, not exercise EKG. Why? Because every coronary artery disease is meaning a coronary artery obstructive disease. Vasospastic coronary artery disease is there. However, there is no need to find them. Why? Because there is no remedy, no definitive remedy, and they are in small proportion. So obstructive coronary artery disease is anatomically problematic. That anatomically problematic, the patients are easily found by the CT coronary angiography, even though they are using contrast eye. And then they have changed it based on evidence, accumulated evidence like the side effect prevalence of side effect of the exercise myocardial SPECT and exercise study, and also dipyridamole or the adenosine study. Like that, they have accumulated evidence. According to the task force team of American Heart Association, American College of Cardiology, American Society of Nuclear Cardiology, and previously Society of Nuclear Medicine, now Society of Nuclear Medicine has given up. There is no information in Society of Nuclear Medicine regarding cardiovascular nuclear medicine. They insisted to call it cardiovascular nuclear medicine, but everyone is calling nuclear cardiology. Okay? If we don't understand the nuclear cardiology, then we are losing half of our patients. So then the survival of nuclear medicine in developing countries are at stake, at risk. So that's the reason why I chose myocardial SPECT for the first subject. Now, I have 13 minutes. Let me explain how we're going to use myocardial SPECT. Here. The first one is Bayesian clinician. So later on, with this one, there is a prior probability, and then posterior probability. Posterior probability meaning after test. Test is giving us a positive or negative results, and then calculation is like this. By definition, prior likelihood is 1 minus p, p over 1 minus p, and posterior is posterior p over 1 minus posterior p. And there is a likelihood, two likelihood can be divided. That's likelihood ratio. Interestingly, that likelihood ratio is sensitivity over 1 minus specificity. If I say sensitivity and 1 minus specificity, and everyone is reminded that sensitivity and 1 minus specificity is a receiver operating characteristic curve, characters, figures. Yes, correct. However, according to this calculation, this is proven. That's QED, right? Based on this one. Test positive, test negative, disease healthy. This probability is sensitivity, and this probability is specificity. This probability is what? Positive predictive value. This the numerical value is negative predictive value. So with this one, we can calculate this one. Here, sensitivity is this one, and specificity is this one. And I made a kind of rephrasing again and again to let you the lead here using this one. This one is not. This one. Treadmill has a sensitivity of 68%, and the specificity has a 77%. I used to ask the medical students. Some of them is exercise EKG, it has a sensitivity to 100%. Some of them saying the specificity after being the dethroned, I mean the challenged by me, real data is just saying that 68%. No. Dr. Asmal, what's the positive finding of the exercise EKG for coronary artery disease? I have used this kind of question as a tease previously. You might just remember. What's the positive sign of the exercise EKG?
Inducible ischemia.
What? you forgot. Dr. Kill, what's the positive sign of the exercise EKG?
Maybe ST elevation.
What?
Maybe ST elevation.
Oh, yeah. So you look like a third grade student. You're totally confused. Okay. Dr. Asmal and Dr. Kill, both of you are terribly wrong. You don't understand exercise EKG. If you say that kind of thing to your cardiologist colleagues, then they are teasing you. They like the Washington University in St. Louis, my colleagues there, they teased me. You are endocrinologists, and there are people, they are doctors who are cardiologists, and all these the doctors will consist of the two types of cardiologists and non-cardiologists. You belong to non-cardiologists. You are a little bit of inferior doctor. That was their joke. If you say so, then you're no. Exercise EKG. Is there anybody who can just kind of answer? But I don't know who would be a best person afterward. I'm going to ask Dr. Hendra Budiawan that in addition to Dr. Asmal and Dr. Gil, I would need 2 or 3 more volunteers who can just answer, correct answer correctly or with more imagination. So the question that I'm asking is a trivial one. Actually, it is being taken care of by the exercise technologist currently. So that's the reason why the internal medicine physicians do not pay attention to. However, to understand the patient, we need that kind of information. Dr. Gil, would you modify your answer? Positive finding of the exercise EKG for chronic obstructive coronary artery disease. Okay, Dr. Asmal.
I'm not sure about ST depression, but because it's chronic obstructive disease is.
All right. Yeah. So you overcame your confusion, and you're trying to figure out the 8 millimeter and 1 or something, and anterior lead is kind of LAD, that kind of issue. No. What I'm asking is, what's the positive sign or finding of the treadmill exercise EKG? Dr. Asmal, would you please add one?
Chest pain.
Okay, yeah. You were reminded. Exercise EKG positive finding, usually not very frequent. However, we are trying to reproduce chest pain, exercise-related chest pain. If there is nothing, then we look for the EKG findings. Do we need to repeat the EKG findings? No. EKG findings, the machine is reading. Artificial intelligence, primitive type of artificial intelligence machine is reading and giving us the ST depression is significant here, here, here. And this is anterior also LAD. that kind of. But you know, the sensitivity is so low, and as I told you, non-diagnostic is 20%. That's meta-analysis data. 1 in 5, they cannot exercise very well because they are too old, because they have a concomitant COPD. You know, that's the reason why myocardial SPECT is better. However, non-diagnostic is 9%. Why? Because we cannot remove beta blocker. We cannot remove the digitalis digoxin, the invalvular heart associated the heart failure patient, or we cannot. We did not teach them very well. Please don't consume caffeine containing the beverages, including coffee. Then caffeine is kind of antagonist of the adenosine. So the receptor is blocked. So so anyway, sensitivity and specificity that. That sensitivity and specificity does not mean anything. And they can mean something. How? This one. Once you do exercise EKG in the patient group, prevalence is 10%, meaning disease is 20 among 200. Okay? Then once you have a positive results, then positive predict value is simply calculated 25%. However, according to not actually this is a Bayesian theorem derived the equation. So you can calculate this one, and likelihood ratio is 0.328, and according to 0.2328, no. Posterior likelihood is 0.328, and then posterior probability is 25%. Interestingly, positive predict value the same. But what I'm trying to emphasize is that positive predict value and posterior probability is the same. No, not this one. What I'm trying to say is, if exercise EKG is giving us the positive results, then among 4 subjects with that kind of positive results, 4 subjects, only 1 patient is having obstructive chronic obstructive coronary artery disease. In that case, ST segment would have been decreased, not elevated. Okay, ST segment is elevated. If you can exclude pericardial effusion, then this is an emergency. However, exercise EKG, EKG ST elevation, ST elevation is the ST elevation appears later than chest pain. We all know that troponin elevation is appearing later. So anyway, here what I'm emphasizing is exercise EKG 20 to 25%. However, prevalence is 50%, the same calculation, 50% to 75%. And then if you do exercise EKG in the group of the subjects, the prevalence 90% in 90 to 96%. Do we need to increase the probability of having coronary artery disease from 90% to 96%? It's absurd. So that's the reason why we do directly coronary angiography. So if you ask your cardiologist colleague that, why don't you do exercise EKG in a typical patient, they would say, it's so obvious. What kind of more information from exercise EKG? And they are concerned. During exercise, patient can collapse, and you're kind of evoking acute myocardial infarction or cardiac death. No, we do coronary angiography, and then one step, the angioplasty with stent insertion, drug-eluting one. That was the case. And what about the myocardial SPECT? If we do the myocardial SPECT, prevalence 10% is increased after positive finding. And then, Dr. Gill, what's the positive finding of the myocardial SPECT?
A positive finding of myocardial SPECT is stress perfusion decrease and partial or fully reversible at rest.
Okay, I found that because Henry Baum is in your university, so
Yeah.
you were educated superbly. Okay, so that's the reason why this one. Fixed defect is not the evidence of the positive myocardial SPECT finding. Okay, fixed means the non-reversible. Okay, we are looking for a reversible one. That positive finding, if there is a positive finding, even though prevalence is 10% and 43%, however, still among two patients, one patient is and one patient is not. Then is it really okay to do the invasive coronary angiography? Why? Because if the patient is an aged person, because of the atherosclerosis, after you did an event for the coronary angiography, you might experience, the patient might experience a stroke because of angiography. So that kind of cost effectiveness should be weighed, right? However, in case of 50%, calculation gives us the 87% with a positive value. 87% is a kind of enough reason to do the next step. So that's the reason why we do here intermediate likelihood imaging study. For myocardial SPECT work, that kind of Bayesian theorem should be based, and here treadmill, unlike treadmill, myocardial SPECT should have this kind of sensitivity and specificity. Even though myocardial SPECT is representing tissue perfusion better than coronary artery obstruction, we are looking for actually obstructive coronary artery disease. Why? Because obstructive coronary disease has a treatment which is proven. Stent insertion, PCI, or the coronary artery bypass graft surgery. For example, my mother, 12 years ago, the first stent was inserted with a two-vessel disease, first stent, 12 years uneventful. Okay, so that's kind of a cure. And finally, then my question is, this is my last question, last 1 minute. Dr. Asmal, no treatment after negative results with exercise EKG or myocardial SPECT. We talked about the positive results. If we got the positive results, we are doing something. Okay. But then what about the exercise EKG? Test negative predicted value with a group of 50% of prevalence. The half of the subjects are prior probability is 50%. And exercise EKG, if we just put the sensitivity and specificity, then data is like that. Sorry, I'm going to just yeah, mute everyone. So meaning we are listening to the next generation nuclear medicine physician, actually, very young, still they listening to this with her mother or father. Okay, negative predict value is 70%. In case of myocardial SPECT, negative predict value is 87%. Dr. Asmal, exercise EKG negative subjects can be observed without PCI or no, not without coronary angiography, contrast angiography. Myocardial SPECT, the negative subjects can be observed without any intervention, any imaging. Coronary angiography is a standard, the one. So, what is your opinion? Exercise
The
EKG
EKG negative patients should undergo further investigation because there can be some false negatives, and perfusion SPECT negative patients can be put on medical management.
Yeah, so that's kind of the current guideline. Then why? So the first question is, Dr. Gill, Dr. Asman correctly told us that exercise EKG negative subjects with a group of prevalence of 50%, they should not be sent to home, outpatient clinic. They need further one, and the myocardial SPECT negative subjects, they can be just sent home. And coming again, if symptom is changing or the whatever, then Dr. Gill, my question is, then why did they do exercise EKG? If exercise EKG positive, then another study. Even though exercise EKG is negative, still another study. Then do we need to do the exercise EKG study in this patient? So just kind of logically, do we need to? But exercise EKG we did not do. Cardiologists did do. Can we challenge them? You did the wrong thing. Really? Not really. So please answer your idea. This is the kind of last question, and I'm going to close. So after 7 minutes of question and answer from you and everyone there.
I think we should consider the cost effectiveness. So we can use the exercise EKG test, even though the negative predictive value is 70%. So.
Okay, please unmute your microphone because I just muted everyone.
Oh yeah, so, sorry.
No. I listened to your. So Dr. Asmal, please understand what Dr. Gill has said. Dr. Gill said there is no need to do based on the cost effectiveness. Exercise EKG should not be done in that patient. Then the cardiologist would become angry. It's our the right and responsibility to do the most, I mean the most least expensive study. In Korea, it's $20. But Dr. Gill, based on logical thinking and reasoning, there is no need to do this patient. So, meaning, let me just remind you. So that's the reason why we have this kind of triage previously. Low likelihood, only in low likelihood patient exercise EKG is working. And intermediate likelihood, 50% of the prevalence, imaging study should be done. That imaging study should not be preceded by exercise EKG. But our national insurance system is going to push do exercise EKG for everyone. Why? Because it's cheap. But according to the study, cost effectiveness, that I too will be involved, we found that it was not the case. So now everyone understands. However, exercise EKG is so cheap. So they do ask exercise EKG. So that was the first point. And second point is Dr. Asma. Then you said, you just told me correct answer. Where is it? Okay, correct answer that exercise EKG negative patients should not be sent home. They should not be under medical observation with medication. They should be studied further with imaging, such as the CT coronary angiography, whether there is any obstruction or not, or even myocardial SPECT study. If the contrast agent is sensitive, then the because of the hypersensitivity, we cannot do any CT study. So recently, so that's the kind of current consensus which is here. Where is it? Which is here. Low to intermediate likelihood CT coronary angiography. Intermediate to high likelihood imaging study. So please be reminded that Leslie Shaw is the eminent the nuclear cardiology epidemiologist. She's good. According to her lecture, you would be really easily convinced. Okay, then my question is, last question, really last question. Here, exercise EKG patients cannot be sent home, but myocardial SPECT can be sent home. But I'm challenging you, among test negative patients, coronary artery disease positive, 70% of diameter or more stenosis patients are 16. Can you ignore 16 subjects among the 200 subjects, or even 103 subjects? Can you ignore 16 subjects having coronary artery disease? If you do coronary angiography, then they would have a significant stenosis in one or more vessels. Is it really okay? Not. Then you did not say anything, but you just kind of gesture. No. Then we are at the same problem. Then why do myocardial SPECT directly coronary angiography? Why not? We need to understand this. That's the kind of a caveat we can just kind of recommend. If things are explained, then we can recommend to our colleagues, our clinician colleagues, that please do myocardial SPECT. If myocardial SPECT is okay, then a patient can be sent home, even though the patient have a 13% of the patients are going to have a obstructive coronary artery disease, chronic coronary artery disease. And why? This is the last question. Okay, because I have used 30 minutes as an introduction, general introduction. I have a little bit of a shortage of time. Anyway, if Dr. Asman solves our problem, then I will finish there without receiving any questions. Sorry for the Dr. Hendra's junior colleagues and others. I have this was the first time, so if you have any questions, please send me an email. I can just kind of let you understand. Dr. Asmal, you understood my question, okay? The same dilemma.
Those can be due to vasospastic angina.
Aha. You are saying that the disease positive but myocardial SPECT negative cases are going to be most likely vasospastic angina. No. If it is vasospastic angina, contrast angiography is showing you normal before organopine challenge. Okay, normal. Then it is considered here not disease. Yes, it is a disease. However, here disease is obstructive coronary artery disease, not healthy, without obstructive coronary artery disease. So not this column, this column. So vasospastic angina is not a solution. Answer, correct answer. So what is the reason? You know, every nuclear cardiologist and cardiologist know that.
The infarction has already happened.
No, not really. It might be old myocardial infarction would have been the reason, yes. Or you might have interpreted incorrectly, yes. But in this case, the correct answer, it is not the correct answer. If it is correct answer, then at least Dr. Kill and all the other audiences in the kind of a connection, they would be relieved. Wow, if myocardial SPECT is negative, even though chronic coronary artery disease is positive, is there, we can send and we can just do the medical follow-up. Dr. Kill, have you any idea struck you? So let me show you the answer here. Please refer to the material you've received. Okay? People studied this outcome of patients with negative stress imaging study, myocardial perfusion imaging, and at that moment, echo. But you know, in this study, exercise EKG here. Annualized cardiac death and myocardial infarction rate. So meaning hard event or MACE, major adverse cardiac event. They call it MACE, M-A-C-E, or CDMI, hard event. Annualized annual follow-up, 1 year, 2 year, 3 year, 10 year, annualized one. SPECT negative is less than 1%. So it is not urgent, even though patients are complaining something. So if patient 1 and the doctor think appropriate, then it's kind of elective procedure, contrast to angiography. So however, how can you decrease the adverse event less than 1 to less than 0.001? No way. 1% meaning among 100%, the 1%. And that 1% was set arbitrarily by the insurance policy that the risk less than 1% does not mean anything. But interestingly, exercise EKG follow-up, the event rate was higher. Okay, all event meaning all event, and then they have they have just shrunken their specimen group patients with coronary artery disease, meaning here patient with coronary artery disease, exercise EKG negative or myocardial SPECT negative. The same, regardless of the coronary artery disease or not. The same. So this is risk stratification. Our cardiologist is saying risk stratification. We say it's a prognostic study. It's just like adverse event study. This is I forgot the source, but it's based on the meta-analysis. Okay. So I think our cardiologist colleagues, they are so reasonable and trustworthy. If you have a chest pain, you can just depend on cardiologist colleagues. They can save us. Okay. Unlike policymakers dealing with the COVID-19, they are making us at risk, unlike the infection experts. But the cardiologists, they are really good. Okay. Then if you come back next week, I'm going to tease you again with the subject of the cerebral vascular disease. However, not like this. Heart is well established. Cerebral vascular disease, the acetazolamide SPECT studies, and then 2 weeks after, you might not like it, but you might just kind of learn from an MD who understood correctly and deeply the tracer kinetic. And 3 weeks later, I'm going to talk about the internal molecular radiotherapy with the dosimetry. But it's again MD's view, so you might just enjoy because this is from a kind of a person who has the same background as an MD and who takes care of who has taken care of the reading. And however, one thing, the reaching so badly that there should be a treatment. The heart has a treatment, cerebrovascular disease has a treatment, and molecular internal radiotherapy has emerging. However, brain diseases, neurodegeneration is not. So I have not included the frustrating neurodegenerative diseases in my. Why? Because our the second semester the discussion is about the clinical application. Okay, see you.